Hello, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, send us your questions or comments at JAMA Network Open on Twitter or in the comment box under the video on Facebook Live or YouTube Live. If you joined us yesterday, thanks again. This is our regular scheduled video. Today, we are talking about the estimated demand for U.S. hospital inpatient and ICU beds for patients with COVID-19 based on comparisons with Wuhan and Guangzhou, China. We've got first author Ruoran Li with us. Ruoran, welcome.
Hi, everyone.
Hi. So can you give us a little bit of an introduction of who you are, what you do, and why you did the paper here?
Yeah, sure. So, hi, everyone. I'm a graduate student at the Harvard T.H. Chan School of Public Health. So I'm working on epidemiology, and this is actually one of my thesis papers. So we're trying to describe the hospital capacity needs of COVID-19 in China, especially in Wuhan, the epicenter, and also another Chinese city, and try to infer that to U.S. cities and think about what are the healthcare capacity needs in the U.S.
So obviously, this is an important question here in the U.S., and hopefully ideally we would learn lessons from what happened earlier in China. So tell us what you did in the study and what you found.
Yeah, so I think one of the contributions of the paper was to actually describe the data in China in terms of the daily prevalence of the severe and critical COVID patients in Wuhan and Guangzhou city. So what we did was that we look at the health commission websites in both the central Chinese government and also local health commission websites to figure out how many patients were there every day, both in terms of inpatients taking up inpatients beds, but also in critical or severe conditions. So they might be requiring ventilators or invasive ventilators, and estimating those numbers every day and think about how those impacted the health care capacity in China.
Okay, great. We've got a health econ Lancaster who's joined us. Welcome. We're talking about COVID epidemiology in China and how it can be extrapolated to the U.S. We've got, I think what's most interesting here is figure one. We've got A and B we can show, which shows the cases in Wuhan. And basically there's very large number, lines that go up, and you can kind of chart out what's going on there. And you can see in 1B, the, kind of the limit of capacity for critical cases is, not even halfway up the meaty part of the curve here. We don't have the graphs for Guangzhou, but basically there are tiny little bits of color on the bottom of the figure there, and not very impressive at all. And I think we're hoping that we had or continue to have a Guangzhou-like experience, but it seems like places like New York have been, I'd say, closer to Wuhan. Have you compared your numbers since you processed them with what our experience has been here?
I haven't actually. So what's interesting is that these numbers in itself are both reflecting the capacity needs, but also the limitations on our ability to capture those numbers. For example, in figure one of the things that we showed is that the designated beds show in figure 1A that in the early February period, it's the hospitalizations, so the inpatients used beds are always the same as designated beds. So those means that there were not enough designated beds to hospitalize or patients that needs care, which means that the data itself is not showing us the full picture of exactly what the needs of the population are. But in China, in Wuhan, in mid-February and afterwards, there were more beds designated than the actual patients hospitalized. That means that we're more confident, a little bit more confident about the data we're capturing about estimating the number of patients in needs. So I think that's also one thing that we're observing in many of the U.S. cities currently is that the data in capturing exactly how many patients there are, how many patients needing this care, sometimes those need some more kind of deeper look into whether these data actually reflects what's happening in the population.
Yeah, that actually kind of, I think that's such an interesting point. I actually wanted to ask you about this, just in thinking about not only given COVID, but just in general, when you're thinking about outbreaks, for example. I'm wondering if you can speak to some of the challenges of, estimating this type of information based on case count data that may be incomplete. You could just tell us a little bit about that. That'd be
Yeah, I think it's so hard. And personally, I'm not doing a lot of direct things related to it, but I know there are a lot of research groups currently working on essentially back calculating from case counts what are the actual cases, numbers of cases and incidents are. And that's very challenging, both because it's contextually, it depends on what's happening with testing and with how patients are reporting themselves to the healthcare system to be tested, and also related to the delays and problems regarding testing and also hospitalization. So I think that's a huge topic, and a lot of current models that are based only on case counts, personally, I find it to be less believable in that they're only relying on this one source of information that we know a lot of different things contribute to it. And these contributing factors may change over time as well. So the trend in case count may not reflect the trend of actual incident cases in the population.
Mm-hmm. Yeah, and we've got Frank Annie and Michael Delaney have joined us. Welcome. We're talking about COVID epidemiology in two cities in China. This is really interesting to me. I mean, just thinking about how in normal times, trying to do things like plan admissions or plan if we're going on an ambulance bypass in real time in a single hospital is incredibly tough. Because we're basically making decisions based on limited data, based on where we're projecting things going in a few hours. And that's at one center, not even collating data across a number of different places together. And then you get into the issues of positive tests, who's getting tested, false negative tests, the testing denominator as a whole. But I think that, overall, the top line numbers we're seeing, is basically we've seen that there's the big fear is that if we don't flatten the curve, we can absolutely overwhelm the critical care and general hospital capacity here. And it looks like, looking at the numbers, that's what happened in Wuhan, but not what happened in Guangzhou. Is that right?
Yeah, that's correct. So in Guangzhou, the city implemented similar infection disease control measures as Wuhan at the same date, almost on the January of 23rd. But at that time, Guangzhou has very few cases back then, and they were able to test all the cases and trace their contacts and quarantine the contacts as well. So I think this plays a huge role in suppressing the case counts to the very low. And you can compare the scale of the two sets of graphs, where Guangzhou has an even smaller scale than Wuhan, but it's still we see very few cases there.
Yeah, Mike Mendelson has joined us as well, and I think again that echoes the U.S. experience, where pretty much the order of a few days or weeks, people or different cities or states went on various levels of shelter in place. For places like New York, the cat was basically already out of the bag to a large degree. I think we're seeing some critiques now in hindsight that if New York had shut things down earlier, it might have done better. But it's hindsight's 2020. I think it's.
Yeah, it's very hard. It's not just that, but also that different cities are different, and maybe population density plays a part as well. We're seeing something in New York, but not in other cities. Maybe that's one reason. But also how people interact and different things. I think it's so hard to predict exactly what's going to happen. And even in hindsight, it's hard to predict what if question. Yeah.
Right. Yeah. I mean, another question we've had about counting numbers is, are the numbers we have accurate? As we said, is a function of testing, but also, when we talk about deaths, are we counting people who died with COVID or of COVID and overcounting? Or on the flip side, what I think we're much more likely doing is undercounting deaths. And if you look at some of the reports of excess deaths, they're vast, almost double of what the actual COVID deaths that are officially confirmed are.
Yeah, and one other thing I'd like to point out is that in this study, we were able to actually count the number of patients needing ventilators from the data that the Chinese government published in terms of number of critically ill patients per day, which is very hard to get actually in the US. And even in one center is probably okay to get, but across the city, I don't think I've seen too much effort, at least in the early part when I was following it, where we actually have an idea of how many patients there are. So that's another thing that's very useful for healthcare planners in terms of planning for response.
Yeah, and Holland Stanton's joined us as well, and yeah, that's just fascinating to me. And in ventilators, it's such a discrete number, and it's such a objective number. You're either on a ventilator or not on a ventilator. It's pretty black and white. It's not questions like, do you have dyspnea or do you have a positive test with a false negative rate? It's very black or white. And it's still very, very hard to get difficult numbers, especially in anything close to real time.
Yeah.
Great. Well, I think that brings us to about the end of this session. Any final thoughts or future directions? What's next?
Yeah, what's next? Well, I'm interested in exploring a little bit more in terms of healthcare capacity issues and how diseases affect those. I think that's sometimes it's my blind spot working in research. It's hard to think about exactly what's happening to patients and also the experience of hospitals. So that's something that's really interesting and I find fascinating in this research. Yeah.
Great. Well, thank you so much for joining us.
Thank you.
Good work. All right. Moving on to our next COVID paper. Angel, what do we have?
So this is a research letter by Li and colleagues. It's clinical characteristics and results of semen tests among men with coronavirus disease 2019. So this was a single center study. It identified male patients over the age of 15 with confirmed COVID-19 by PCR. And essentially, they enrolled patients who then consented to also provide semen samples. So they had 38 patients ultimately enrolled. Of the 38, 23 or about 60% had achieved clinical recovery, and 15 or about almost 40% were sort of in the acute stage of infection. And they found that 6 patients had SARS-CoV-2 in semen. I'm assuming this is via PCR.
Yep.
And so that included 4 of the 15 in the acute stage and 2 of 23 who were recovering, which is kind of interesting, actually. Just thinking about sort of the trajectory of illness and looking at the sort of positivity and semen kind of associated with that. So they didn't find any significant difference between negative and positive tests by age, disease history, days since onset, hospitalization, or since clinical recovery. So this is a pretty small sample. So, it's hard to make too much out of it, but it is sort of interesting. I think we were talking earlier, there have been some other studies that have looked at, isolating positive PCRs from other sort of bodily fluids. And so what exactly this means, I don't think we can make too much out of it from this sample, but it does give us a little bit more information, I think, which is sort of interesting.
Yeah, absolutely. There was another study that I'm forgetting where I saw it that showed no positive tests in semen a couple weeks ago. This one, I think, is a proof of concept. I think this is the kind of study that's gotten, not surprisingly, a little bit of press and kind of like social media coverage, just because it's kind of is COVID an STD, type study. I think the real physiologic questions or the hypotheses are kind of interesting. Does it, is it crossing, the blood testes barrier? What does this mean? Is it going to be in eyes? Is it going to be in brains? Those kind of lessons.
Right.
Because ultimately the bottom line is, it's very hard to, even if the virus wasn't in semen, it's probably going to be transmitted sexually based on other activities. As I forget who said it on Twitter a while ago, someone was doing this is right at the beginning of the pandemic in the US. Somebody was talking about, is it safe to have sex during COVID? And their answer was, yeah, if you can figure out how to do it while you're 6 feet apart, sure. Yeah. So it's interesting. And I think really, is that not just to be I don't know, school marm, but like the serious physiologic questions are the interesting ones here.
Yeah, no, I agree. So, and I think, in other emerging diseases, we see this sort of, just trying to figure out what it all means. I think it's an evolving process here as well.
So we've got one of the viewers who asked, is COVID considered an STI? So I think at this point, really, it doesn't matter if it's sexually transmitted directly via semen or bodily fluids. I mean, if you're wearing wonderful PPE at appropriate prophylaxis, there's probably going to be some exchange of droplets and close contact during sexual activity. So I don't know. I'm going to dodge that question. Do you have any thoughts?
Yeah, no. I mean, I think that's right. I think that I don't think this study is necessarily saying anything one way or the other, just that they've isolated, some viral remnants from semen. And so what to make of that, it's unclear. But I think you're right that droplet transmission clearly is the driving factor here.
Yeah, and that's another good point that you're implying is that the PCR is testing RNA, which means that we're detecting RNA, not necessarily active disease-causing virus. And that's one of the things that's been interesting as our understanding of the virus changes over time. At first, there were some concerning features about either patients testing positive after having tested negative and recovering, or about say a positive test from toilets from patient rooms. And it seems to be that most of that is just detecting RNA fragments and not infectious virus. So some good news, some glimmers of hope here. All right, so moving on, you've got the next paper too. What do we have?
Yeah, so this is different. This is the evaluation of internal medicine physician or multidisciplinary team co-management of surgical patients and clinical outcomes by Shaw and colleagues. This is a systematic review and meta-analysis, and they were trying to understand the association of having internal medicine essentially involvement with clinical outcomes as well as some health systems outcomes compared with just usual surgical care among adults who undergo surgery. And I think the background, at least from my experience, is sort of this idea that in certain hospital systems or hospitals, some surgical patients will have either sort of be co-managed with the internal medicine team, or in some cases a geriatrics team, for example, depending on the type of surgery and the et cetera. And versus those patients that are sort of considered medically complex being managed primarily by an internal medicine or family medicine or geriatrics team with the surgical colleagues sort of assisting essentially, or kind of taking care of the surgical part of it. And so the primary outcome here was length of stay. There were several secondary outcomes, including 30-day readmissions, inpatient mortality, medical complications, functional outcomes, and costs. So ultimately, 14 studies were included. And I think the conclusions are a little bit nuanced because overall, there was no significant association with length of stay or mortality. Given these types of interventions, the most interventions being this co-management kind of approach. But there was only one randomized control trial that was included in these 14 studies, and that study found no difference as well, though there was seen to be a reduction in medical complications with co-management. And then among the non-randomized study, there was some low-quality evidence that internal medicine physician-led models were significantly associated with reductions in length of stay and mortality. The caveats being here that the risk of bias was fairly high, I think over 70%. There was a lot of heterogeneity, particularly in the subgroup analyses. So it's hard to kind of know what to make of it. And I think the authors aptly kind of conclude by saying, we really should have some RCTs or better kind of quality research to kind of look at this question, which I think is a pretty common clinical situation.
Yep. Yeah, absolutely. I find this fascinating. I'm an ER doc, so my perspective is a little more, I just want the path of least resistance and the easiest way to move my patients through so they can get the care they need. And I can definitely see both sides. And I've worked at a number of different hospitals with a number of different kind of cultures and practices on this, from, some place where the surgeons are very proud to manage as much as they can by themselves, to some place where almost everybody gets admitted to hospitalist or medicine services. And there's certainly pros and cons to both of them. In some ways we find that, specialists do better as they specialize. And if it's the surgeon specializing in operations while the hospitalists are managing the hospitalization, that's great. But there's also, I think I would say that surgical and operative aren't synonyms, and that surgical management of surgical problems is sometimes best done by surgeons. And I don't know, I feel like unfortunately a lot of places end up in this unhappy valley where, like in our place, most patients with surgical problems go to medical services, but there's always a chance they're going to go to the surgical service. And really, I think I think that the easy fallback answer is these are things that should be worked out beforehand with what's the overall protocol, what are the typical things, and what are the rules to follow, as opposed to sense
for the patient, right?
Yeah.
Every patient is different and has a different situation going into surgery and coming out of surgery.
Yep, very, very, very good point. Tim Frenzel is joining us as well. Welcome. We're going to move into our last paper, not patient. This is an interesting one, the association of long-term strenuous physical activity and extensive sitting with incident radiographic knee osteoarthritis by Chang and colleagues. So basically, the whole point of this study is that there's kind of this trope that, the 50-year-olds, weekend warriors who do triathlons all the time wear down their knees and need their knees replaced the day they get Medicare. And it turns out that that's probably not what the case is. So what they did in this study, it's 1,200 patients, average about 58 years old, BMI about 27, so pretty typical Americans, getting annual evaluation for 8 years as part of this osteoarthritis initiative longitudinal cohort study that started in 2004 at 4 U.S. sites. They're patients who don't have any radiographic disease when they started this study, but are at risk for knee osteoarthritis. I imagine the greatest risk factor is just kind of having knees and continuing to have birthdays. And they each year estimated their weekly strenuous activity using this PACE questionnaire, as well as the estimates of their extensive sitting. You're sitting more than 4 hours a day for 5 days a week, a number of measurements like gait speed, Womack pain scores, and things like that. Basically found, not terribly surprising, that things like age, BMI, and knee pain were associated with decreased activity, whereas things like college graduation, quadricep muscle strength were associated with increased or improving activity. And really, there's a lot of different things going on, but the bottom line is that there was no correlation between exercise and radiographic osteoarthritis, and some signal towards actually protection. So people who were people who were able to exercise more were less likely to have radiographic osteoarthritis.
Yeah. And I can't recall, did they classify the types of physical activity? Because I would imagine things like that are weight bearing or strength training that's considered strenuous, maybe different compared to like running marathon.
I don't think they categorize them that much, but they basically divide it. We have figure 2 here into strenuous activity and low to moderate strenuous activity, which I think gets what you're getting at. So not so much qualitative, but the magnitude of activities, and they're actually pretty similar results for both.
Very interesting stuff.
Yeah, and it's interesting. I mean, I think the whole idea that we're just kind of simple machines that wear down is complicated because we're alive. And, if you're using your joints, does that mean I don't know, I'm totally hand waving making this stuff up, but, does that mean you're like stimulating your cartilage to protect more and grow or recharge, or something like that? Yeah.
I guess the other thing would be is they were really looking at radiographic evidence, right? Which is always, it's not 100% perfect necessarily correlated with the person's symptoms or whatnot. So all complicated stuff.
Right. Although the flip side is that's probably, I would imagine, a big part of what gets wrapped up in our brains with who actually gets treatment or surgery for these, even if it's not intentional. Just because our brains are simple with this sort of thing. And honestly, look, I'm not a surgeon. I can't pretend to make this sort of stuff. But, when I do simple things like use my suturing skills to sew clothing, sometimes I forget that, the clothes aren't going to grow back, unlike the people who I repair at work. It's a very different thing. So a lot of, repairs that I do at home often end up failing over time. And, my people's sutures don't end up failing 2 years later because they healed in the meantime. My, button that I sewed on doesn't heal. Yeah. All right. That's all we got this week. Thank you for joining us, especially if you joined us yesterday as well. It's been a busy week. So, of course, get these papers and more at JAMANetworkOpen.com. Everything is open access and free to access. We've got new papers that come out every weekday at 10 a.m. Central Time. And, of course, join us next week, May 19th at 3 p.m. Central Time for more JAMA Network Open Live. Thank you. Take care.
Bye.